Good morning, everybody. I'm Dr. Kaustubh Mohite, presently pursuing fellowship in Paediatric Pulmonology and Sleep Medicine in Aster CMI Hospital. Today, we'll be talking about yet another an interesting topic from a pulmonology point of view. And not only pulmonologists, but also every single pediatrician should know when and how to diagnose this disease, cystic fibrosis. Cystic fibrosis, even as such, might not be that a common disease, but now we have been seeing that the prevalence of this disease is is gradually increasing in our community as well. So before we start today's talk, I would like to take you through a few cases. So this is our first child, 1-year-old male child, born out of third-degree consanguineous marriage, a birth weight of 2.4 kg. A mother gives a typical history that the child did not pass stool in the first 24 hours and later passed only after giving enema. In the past 1 year, the child has been hospitalized around 3 times for the same complaint of pneumonia, for which IV antibiotics were given for 7 to 10 days. The child still passes stool, which is oily in consistency and stains the diaper. He has been having persistent cough, which is started since last 6 months, which is recently increased. On examination, the height and weight of this child is less than third centile. There's mild baseline tachypnea present. The child has wet bouts of cough. When you put your stethoscope on his chest, air entry is decreased in bilateral basis. Bilateral wheeze and crepitations are heard. You do a chest X-ray, and this is what you see. If you see closely, I've just highlighted the left lower zone of this X-ray. You can already see thickening of bronchial walls seen, which is early signs of bronchiectasis. Just keep this image in mind as we move to the next case. The second case is an 8-year-old male child, again complaining of recurrent episodes of wet cough, which last for 2 to 3 weeks at one go. He has received multiple courses of oral antibiotics, after which the cough relatively subsides, but after a period of 2 to 3 months, it again flares up. Presently, he is brought with complaints of wet cough, fever, hurried breathing. There are no GI complaints. You examine this child, again, height and weight is less than third centile. The child is febrile. He has significant tachycardia and tachypnea for age, not maintaining room saturations. Rates of around 45 to 50 per minute. Air entry is reduced in the left infrascapular region. Bilateral significant crepitations are heard. And this is his X-ray. As you can see, he's got significant involvement of the left lower zone of his lung. As you move ahead, the third case is a 12-year-old girl who's a sister of the second case. She was apparently all right till 10 years of age. Later, she observed that she had only complaints that she had, but she was passing oily, greasy stools after consumption of high-fat diet, especially non-vegetarian diet, which contains a lot of red fiber. So she was passing oily, greasy stools. They were on and off, non-significant cough. The growth was relatively preserved. The weight was around 3 to 58 centile and height was normal for age. Vitals were stable and chest was absolutely clear. So if you take all these 3 cases together, the first case is a 1-year-old early presentation, having both respiratory as well as GI complaints, having significant failure to thrive. And the child was born out of consanguineous marriage. The second year had only respiratory complaints, no GI complaints, but was having failure to thrive, but had presented in acute exacerbation. The child had fever, significant tachypnea, tachycardia, and desaturations. Whereas the third case had only GI complaints, no respiratory complaints, no failure to thrive, but had a positive family history as she was the sibling of the second case. So all these cases should be suspected to have cystic fibrosis. However, all have different severity of disease. So our today's topic, what is cystic fibrosis? What is the basic underlying problem of this disease? How does a child present? How would you confirm this diagnosis? How would you categorize CF patients? And the last few evidence-based studies on what is the importance of early diagnosis and management. So what basically is cystic fibrosis? It is an autosomal recessive genetic disorder caused by mutation of CFTR gene. Now the CFTR stands for cystic fibrosis transmembrane conductance regulator. Now what this causes is that it causes reduction in the airway surface liquid hydration, And because there is dehydration of the airway surface liquid, the child is more prone to having infections and severe forms of inflammations. So based on, there are various different mechanisms which I'll be covering in the future slides, in the further slides. And all these mechanisms eventually land up to have the same problem. So a normal CFTR protein has three functions. Or these, as you can see, is the epithelial of airway mucosa. A CFTR gene is responsible for efflux of chloride ions, influx of sodium ion, as well as efflux of bicarbonate ion. So this protein causes chloride and bicarbonate ion to be thrown out of the cell into the lumen and get in sodium channel into the extracellular layer. In cystic fibrosis, all these three mechanisms are hampered. So what exactly happens is that there is down regulation of chloride transport, up regulation of sodium transport, whereas down regulation of bicarbonate. So what the two channels which were causing efflux of chloride and bicarbonate are down regulated. Hence, there is ineffective efflux, and so these two ions stay in the cell. As well as there is upregulation of sodium channels. So the sodium which has to be taken inside, there is over exaggerated functioning of this channel. So as you can see, both sodium and chloride stays in the cell. It causes an osmotic gradient which pulls water along with it inside the cell, and hence water moves along these sodium and chloride molecules, leading to hyper concentration of the mucus. So as you can see, this is a lining of your airway mucosa, the mucociliary cells, goblet cells, basal cells. This is the layer of the airway surface layer, airway surface fluid, and the layer of mucus over which there is, which causes movement of the particles from distal to the proximal airway. What happens in CF is that there is hyper influx of sodium and down regulation of efflux of chloride. So both sodium chloride stay in the cell, causing increase in the osmolarity in the cell, causing water to be pulled inside the cell, causing dehydration of the airway surface fluid. So when you talk about clinical manifestations, we should differentiate into either age-wise or system-wise. First, we'll go with age-wise. A child initially in his early infancy will not have respiratory complaints. They will have GI as well as hepatobiliary complaints predominantly. So there will be significant failure to thrive, steatorrhea, meconium ileus, rectal prolapse, prolonged neonatal jaundice, and early signs of chest infection. As the child grows, then he starts showing respiratory signs as recurrent chest infections, idiopathic bronchiectasis, and they also continue to have GI complaints like steatorrhea, the intestinal obstruction. These, as we saw in the third case, they will very definitely have a positive family history as well. As the person grows into adulthood, they will have other add-on complaints as in azoospermia, bronchiectasis will continue, acute sinusitis will turn into chronic sinusitis, there's allergic bronchopulmonary aspergillosis, biliary cirrhosis, diabetes mellitus, which is related to cystic fibrosis, portal hypertension, and cholestasis. Now, if you see all these complaints into various systems, we know these sinopulmonary and GI symptoms, everybody knows. A child coming with persistent respiratory complaints, recurrent respiratory infections, wheeze, clubbing, indicating some chronic infection, any culture which is very specific for CF organisms like in the first decade being positive for staphylococcal, whereas in the second decade being more predominantly Pseudomonas. GI complaints like meconium ileus, rectal prolapse, distal intestinal obstruction syndrome, pancreatic insufficiency. These are all which most of the practicing pediatrician know. These are a few which we should be knowing a bit extra about these patients. So a child who's coming with severe hypokalemic metabolic alkalosis, as in Pseudobarter syndrome, you should think about cystic fibrosis. A child having hemorrhagic disease of newborn because of vitamin K deficiency, you should think about cystic fibrosis. A child coming with persistent hypoproteinemia causing generalized edema, anasarca, you should think about cystic fibrosis. Talking about the diagnostic criteria, it should fit both clinical as well as lab evidence. So clinical should be either one of the symptoms which we saw earlier, or a CF positive family history, or a positive newborn screening, along with one of the three tests which should be positive, either a sweat chloride test, a nasal potential difference, or two disease-causing mutations in CFTR. So talking more in detail about the diagnostic modalities, we have these 5 basic modalities, being newborn screening, chloride test, nasal potential difference, genetic analysis, and end organ effect analysis. So we'll be talking about each in a bit detail. First of all is our newborn screening. So this test mainly measures about the trypsinogen levels in the blood. Now what happens is that in an infant pancreas, there is this chemical secreted known as trypsinogen. This trypsinogen is further transported to the intestines, where it is converted into trypsin. And this trypsin has a very important role of breakdown of complex proteins into peptides. Now, as we know, because in cystic fibrosis, there is difficulty in secretion of all these chemicals from one organ to the other. There is mucus plug in the pancreatic duct, which prevents this trypsinogen from reaching the small intestine, which results in decreased breakdown of this food. And so there is no conversion of trypsinogen to trypsin, and the levels of trypsinogen increases in the blood. So there have been various studies conducted all over. This was one major trial which ended in 2014, in which there were 586 cases, which showed a significant improvement in cases with cystic fibrosis with early diagnosis due to newborn screening. Next, the most important is a sweat chloride test. It is considered as the gold standard for diagnosis of cystic fibrosis. There are 3 ways for conducting this test. The most traditional way was something called as Gibson and Cook, in which you use a filter paper, you measure, you take an appropriate this square inch of a filter paper, you keep it, you collect the sweat, you exactly measure the amount of sweat collected, the grams of sweat collected, then you have to add a specific reagent. It's a very complex procedure, which is hard. It's still being utilized in some units, but it's not as effective as the more sophisticated techniques that we are recently using. Then comes the nanoduct, and finally the macroduct, which is the most sophisticated way of checking this sweat chloride analysis. Now, the patients which should be selected are very specific. A child should be more than 2 weeks of age, because it has been found that there is a transient elevation of sweat chloride in the first 1 week of age. The child should be greater than 3 kgs. The child should be normally hydrated, as in there should be no signs of dehydration. The child should not have any significant systemic illness. Usually, we don't prefer any kid in PICU, or even for that sake in ward admission, who is kept in air-conditioned environment for sweat chloride analysis. So taking you through a basic, how do you do this? I have created this small video. I hope this will be helpful to you. So this is a sweat inducer. There are 2 electrodes and a sweat analyzer. So there are basic 3 steps. First is sweat stimulation, sweat collection, and analysis. I'm putting the pilocarpine gel on the electrodes, which will induce sweating. The red is a positive, black is a negative electrode. There's a small current of 5 milliamperes, which is sent through this sweat inducer, which causes iontophoresis. Once the site is cleaned, at the site where I had the red electrode put, now I put the sweat collector. You can see that because of the hydrostatic pressure, the sweat is being collected in the circular capillaries. As less as 6 to 10 microliters of sweat is adequate for sweat chloride analysis. So I'm taking out the loop of the capillary. You can see the layer of sweat being collected. And then finally, I attach it to the sweat analyzer. Now the reading that you see is the total amount of sodium plus chloride. So 144 is the value of sodium plus chloride. So in order to find what was the chloride levels, we divide by 2, which is 72. Anything more than 60 is considered as abnormal, positive for sweat chloride. This is an important slide where you should be knowing where the test could be false positive or false negative. In cases like severe malnutrition, atopic dermatitis, hypoparathyroidism, adrenal insufficiency, G6PD deficiencies, Klinefelter syndrome, the test might still be positive in spite of the child not being cystic fibrotic. Whereas in cases where there is edema, dehydration, hypoproteinemia, mineralocorticoid, you're treating a child with a steroid, as well as some rare cystic fibrosis mutations, the test might still be negative in spite of the child being actually a case of cystic fibrosis. So a few add-on points. A normal adolescent and adult can tend to have a higher levels of cystic fibrosis, sweat chloride levels, which is up to 60. So hence borderline values are considered, should not be treated as positive for cystic fibrosis. As I've already mentioned, there are some atypical CF mutations in which you may still get normal or intermediate values of sweat chloride levels. The commonest cause of false positive is either operator inexperience or the child is having eczematous skin. And the levels more than 150 is not physiological and you have to repeat the test again. Initially, before 2018, the guidelines said that levels above 40 to 60, levels between 40 to 60 were considered as intermediate, which was recently changed after 2018 as 30 to 60. So the kids who were considered from 30 to 40, initially which were considered as normal, were again reinvestigated. So they investigated around 3,000 students, 3,000 cases in the last 5 years from hospitals in America. And they identified there were 125 cases which had to be reclassified from non-cystic fibrosis to intermediate. And they did a cystic fibrosis mutation and they found that 8 were positive for cystic fibrosis. So this was again another landmark study in which they changed the range from 40 to 60 to 30 to 60, which increases the yield of diagnosis of cystic fibrosis. Along with sweat chloride analysis, these are two different ways in which you could indirectly diagnose cystic fibrosis, that is sweat osmolarity or sweat conductivity. So osmolarity was a total amount of solute concentration present in millimole per kg in your sweat, and values more than 200 were consistent with cystic fibrosis, whereas conductivity represents the non-selective measurement of ions. So the amount of ions which were measured in this sweat with a cutoff value more than 90 being positive for cystic fibrosis. So out of these two variables, conductivity was found to be more, correlating with sweat chloride analysis, having so conductivity more than 90 millimoles per liter, had 83.3% sensitivity and almost 100% specificity, 91% of positive predictive value and almost 100% of negative predictive value. This nasal potential difference measurement is a very theoretical thing. Practically, we cannot do in pediatrics, but still is another way of diagnosing cystic fibrosis. So what you do is there are two electrodes. One is the exploring electrode, which is placed in the inferior turbinate of the nose, and the reference electrode, which is placed in the subcutaneous area on the forearm or any abraded skin. It was found that the baseline potential difference was way negative in cystic fibrosis as compared to normal people. Again, in cases in which there were inconclusive diagnosis with CFTR mutation as well as sweat chloride, this test has been used, but again, it is mainly for research purpose. Next comes the most important, that is mutation analysis, that is genetic tests. So we have been using this for confirming the diagnosis of cystic fibrosis. But the thing is that there are more than 1,900 different CF genes, which in which if mutation happens can cause cystic fibrosis. Even though delta F508 is the most common gene mutation, it is seen mainly in the Caucasian population. So hence, you cannot correlate the same data to our Indian Dravidian population. So other common mutations involve 394 deletion TT, R117H, or G551D. So each mutation causes the same disease pathology by different mechanism. We'll see how this happens. So in order to cause cystic fibrosis, the mutation should fulfill all these 4 criteria. The change in the amino acid sequence should severely affect the CFTR synthesis and or function. Any deletion, insertion, or nonsense mutation which introduced should cause a premature termination. So there should be a stop mutation. There should be alteration of the first 2 or the last 2 nucleotides. And there should be a complete novel amino acid sequence, which is not a normal variant. So based on that, we have 6 classifications of various ways in which it can lead to a cystic fibrosis. So first, when you see is production, class 1 is production at the genetic level itself. So there is reduction in the quantity of expressed CFTR protein. So at the place where the protein is produced, there itself you have a problem. The second is processing. There is abnormal CFTR processing. So once the protein is out, it is abnormally processed in the lysozymes. And that is where delta F508 happens. So delta F50 mutation is a problem in the processing of the CFTR gene. Next comes regulation. There is aberrant channel function. Aberrant channel function. The protein is formed, it is processed normally, but the channel is not functioning properly. So this is class 3. Next comes class 4, which is abnormal conduction. There are changes in the conductivity of the channel. So the gene is formed perfectly fine. It is perfectly processed. It has reached your the channel, but the channel is not performing its function. Next comes production, that is limitation of transcriptional regulation. So along with class 1, class 5 is again at the nuclear level. And finally is turnover. There is increased turnover of CFTR channel causing decrease in its half-life. So 6 is increase or accelerated turnover. So these are various different ways, but eventually leads to the same disease pathology. So in order to confirm cystic fibrosis, you require at least 2 cystic fibrosis disease causing mutation. However, this is highly specific, but not very sensitive. This is because, as I've already told you, based on various different geographic regions and human race, the mutations vary. Hence, you should be knowing what is common in your ethnical region, and hence you should be testing for those specific mutations. So even if at all you fail to find 2 CF mutation from a selected or extended panel, does not exclude the diagnosis of cystic fibrosis. So recently in 2019, there was this another added on classification. The only thing that we should be knowing is class 1, 2, 3 are more severe causing disease, and class 4, 5, 6 are less severe diseases. This was also made because in order to based on the classification, the therapies, the treatment modalities also vary. So they have a huge database called as CFTR2, in which they provide information about specific CF mutations to patients, researchers, as well as for general public. So they have differentiated every single mutation in a way that whether it is actually causing disease or not, or how is the clinical characteristics of this disease, as in what would be the average lung function, what would be the pancreatic status, whether the child will be affected with Staphylococcus or Pseudomonas in the coming years. Every single mutation has its own characteristics. So based on various different types of genetic mutations, you have various phenotypes. So they are mainly differentiated into 4. One is classic cystic fibrosis, atypical or non-classic, CFTR related disorder, and the last is cystic fibrosis screening positivity with inconclusive diagnosis. So we'll be going through each of them. A classic, as I've already mentioned, has a positive sweat chloride test plus 2 CFTR mutation positive. An infant will mainly present with GI complaints like meconium ileus, rectal prolapse, unexplained malnutrition, prolonged jaundice. As he grows up, will later turn to have recurrent chest infections, malabsorption, pancreatic insufficiency. Even though insufficiency is seen only in around 85% of classic CF. Next comes atypical or non-classic, also called as equivocal or variant CF, in which the sweat chloride may be either normal, equivocal, or positive. The mutation analysis may reveal 1, 2, or even no mutation. Even if at all it has 2 mutations positive, they're usually mild variant, which cause only partial CFTR expression and function defect. Next is what we call a CFTR related disorder, in which they may have only single organ specific CF manifestations. They are mainly divided into 3 entities. One, which is seen later as the person grows up, which is congenital bilateral absence of vas difference causing azoospermia and infertility, acute recurrent or chronic pancreatitis, and finally disseminated bronchiectasis. And finally is a cystic fibrosis screening positivity and inconclusive diagnosis, also called as CFTR related metabolic disorders. Previously it was called as pre-CF, as they have not yet manifested with any of the symptoms or end organ dysfunctions, but they still are positive for screening tests. Screening test mainly involves your positive newborn screening with two CFTR mutations or mutations with equivocal sweat chloride levels. The important thing is that in the future, they may develop the disease as the age progresses. The final way of diagnosing cystic fibrosis is assessment of the end organ effects. So if you do a CT scan, you may get HRCT showing early changes of bronchiectasis, a CT of paranasal sinuses showing polyps. You can evaluate for pancreatic function test by fecal elastase levels, microbiological cultures showing very typical organisms like Staph aureus or Pseudomonas aeruginosa, and semen analysis showing azoospermia and infertility. So coming to our last few slides, why early diagnosis is of utmost importance. There was a systemic review done from 22 countries, which have shown that there is an improved health which was consistently observed in association with diagnosis via newborn screening compared with cohort diagnosis later in the symptomatic presentation. This is a very interesting study which was done way back in 1977, but I would like to quote this as I end my session. There were 16 sibling pairs. So 16 pairs of cystic fibrosis siblings, which were studied through 7 years. The thing what they did was, one of the sibling was diagnosed early, before 1 year of age, before any of the pulmonary manifestations were there, and the other was diagnosed later. They have given the similar therapy to both these siblings, and they found that at the end of 7 years, there was a significant difference in chest X-ray scores, total clinical scores, residual lung volumes, and the ratios of residual volumes to total lung capacity in the child which was diagnosed earlier. So that proved the fact that early diagnosis is of utmost importance. So the final take-home points after this session were that the cystic fibrosis is usually a presentation with typical symptom complex. A detailed family as well as past history is very important to diagnose CF. CF has different genetic mutations in different geographic regions. Now that we know that the symptom complexes are very easy to identify, we should have a very low threshold in diagnosing CF. And we know that we are very fortunate to have all these sophisticated diagnostic tests like macroduct analysis in our hospital. So we should be utilizing it more often. And in case of suspicion, urgent referral to pulmonologist is essential. So these are all the references that I've taken to make this presentation. The video that I just showed you was from my own channel, which I make on my own. I've put various pulmonology related videos, intervention related videos, so you can go through it once. Thank you. Any questions?
Thanks, Kaustubh.
Thank you, ma'am.
I think that was quite elaborate. I think some of the diagnostic modalities of what we have was quite useful to know.
Okay.
Any questions from anybody else? I wanted to know a little bit about the genetics. What are we doing here? Are we testing what genes are common?
Madam, the most common again.
Yeah.
Yes. So the most common gene that we are testing is again delta F508. But what we have seen is that even though it is most common in the Caucasian group, even though if you are still strongly suspecting cystic fibrosis and even if the gene comes negative, it is rather preferable to send the whole exome, whole clinical exome, which will take care of all other cystic fibrosis genes as well. So first and foremost, because of the cost effectivity, we do send delta F508, which is most common, followed by still if we strongly suspect CF, if the test comes negative, then we send whole clinical exome. Hello?
Thank you. Thank you. Thank you.
Yeah.
Anyone else with any questions? Okay, wonderful. Thanks a lot, Kaustubh.
Thank you, ma'am.
Thank you for presenting.
Thank you.
Thank you all.